You may have seen the advertisements on social media, on YouTube, in the health groups and forums where millions of adults with arthritis exchange advice, experiences, and the always present search for anything that might actually help. Mounjaro for arthritis pain. Mounjaro for joint inflammation. People posting that their years of morning stiffness disappear within days of their first injection. That they can finally climb stairs again. That their rheumatologist is amazed. And you have probably also seen the counter reaction. The skeptics. The warnings. The voices saying that this is a diabetes drug being hyped as something it is not, that the people selling hope around Mounjaro for arthritis are doing something dangerous, misleading, and potentially harmful. So which is it? Is Mounjaro an innovative treatment that the medical establishment is slow to recognize? Or is the enthusiasm around it a dangerous example of misleading advertising that could send arthritis patients toward an expensive, unapproved medication with serious risks? Instead of the evidence-based treatments that genuinely work, the honest answer is more nuanced than either of those positions and more interesting. Because what the research actually shows about Mounjaro and arthritis is both genuinely promising and genuinely limited, and understanding precisely where the evidence sits, what it shows, what it does not show, and what the gap between clinical evidence and social media claims actually looks like, is exactly the information that every adult with arthritis who has encountered Mounjaro in any form deserves to have. Today I am going to give you that complete, evidence-based picture. Not the pharmaceutical marketing version. Not the skeptic dismissal version. The actual science, including its genuine promise and its genuine limitations, explained with the honesty and specificity that this channel has always prioritized. Before we go any further, subscribe to this channel right now if you want evidence-based health guidance specifically designed for adults managing arthritis. We create this content because you deserve accurate, complete information, not marketing and not hype. Hit subscribe. Let us start with what Mounjaro actually is, because understanding the drug is the prerequisite for understanding the arthritis conversation. Mounjaro is the brand name for tirzepatide, a prescription medication developed by Eli Lilly that belongs to a novel class of drugs called dual GIP and GLP-1 receptor agonists. GIP stands for glucose-dependent insulinotropic polypeptide. GLP-1 stands for glucagon-like peptide 1. Both are gut hormones, incretins released naturally after eating that regulate insulin secretion, appetite, gastric emptying, and energy balance. Tirzepatide mimics both hormones simultaneously, making it the first dual incretin receptor agonist to reach clinical practice. Mounjaro is FDA approved in the United States for the treatment of type 2 diabetes mellitus in adults. Under the brand name Zepbound, tirzepatide has also received FDA approval for chronic weight management in adults with obesity or with overweight accompanied by at least one weight-related health condition. What Mounjaro is not, and this is the foundational clinical fact that every arthritis patient considering this medication needs to understand, is an approved treatment for arthritis. Not for osteoarthritis. Not for rheumatoid arthritis. Not for any form of joint disease. When arthritis patients use Mounjaro in the hope of joint benefits, they are using a medication off-label outside the indications for which it has been reviewed, tested in the populations most relevant to arthritis, and determined by a regulatory authority to be safe and effective. That distinction matters enormously, not as a technicality, but as a statement about what we actually know versus what we hope. So let us examine what we actually know. And while tirzepatide's dual GIP and GLP-1 mechanism is predicted to reduce inflammation similarly to semaglutide, this prediction has not yet been validated in comparable osteoarthritis-specific clinical trials. Second, in the STEP9 trial, the semaglutide group lost significantly more weight than the placebo group, and disentangling the direct anti-inflammatory contribution from the joint load-reducing contribution of weight loss was not the trial's primary design goal. Drop a comment below right now and tell us, have you tried Mounjaro or any GLP-1 medication and noticed any change in your arthritis symptoms? Or are you currently considering it? Your experience is valuable to everyone in this community. We read every comment. The direct tirzepatide and osteoarthritis evidence is emerging but not yet definitive. Research presented at the American College of Rheumatology annual meeting in 2025 examined the impact of tirzepatide on musculoskeletal pain and analgesic use in non-diabetic patients with overweight or obesity, finding signals consistent with benefit. An ongoing randomized controlled trial, the STOP-NEO-A trial, registered on clinicaltrials.gov, is specifically evaluating tirzepatide in knee osteoarthritis, assessing not only symptoms but structural outcomes through MRI. This trial represents the kind of rigorously controlled, disease-specific evidence that would actually establish whether tirzepatide works for osteoarthritis and through which mechanisms. For rheumatoid arthritis, the evidence is similarly promising but preliminary. A chart review reported in the American Journal of Managed Care examined 173 patients with rheumatoid arthritis who were prescribed semaglutide or tirzepatide, finding significant improvements in inflammatory markers and pain scores compared to patients who did not take GLP-1 medications. This is observational data with significant limitations. It cannot establish causation and does not control for confounding variables with the rigor of a randomized trial. The Autoimmunity Review's 2025 review explicitly concludes that additional well-designed studies are needed to test GLP-1 medications against standard rheumatological treatments and to provide long-term safety data. The potential is real. The evidence is not yet definitive. The GIP receptor dimension of tirzepatide's dual mechanism adds another layer of potential clinical relevance that distinguishes it from the semaglutide data constituting most current clinical evidence in arthritis. GIP receptors are expressed on immune cells including macrophages and T cells, and GIPR agonism has been shown to contribute to anti-inflammatory signaling through pathways that may complement and enhance the GLP-1 receptor-mediated effects. Whether the dual agonism of tirzepatide produces meaningfully greater anti-inflammatory effects on joint tissue than GLP-1 agonism alone, an important question given that most clinical evidence in arthritis comes from GLP-1 only agents, is another question the tirzepatide-specific trials are designed to address. Now, let us turn to the advertising question, because the distinction between what the science shows and what is being advertised in spaces where arthritis patients seek information is significant and, in some cases, genuinely misleading. The social media claims around Mounjaro for arthritis range from the reasonable adults with obesity-related osteoarthritis reporting meaningful pain improvement after significant weight loss, which is an entirely plausible mechanism, consistent outcome, to the exaggerated claims that Mounjaro directly regenerates cartilage, specifically targets arthritis inflammation, or constitutes a superior alternative to evidence-based arthritis treatments. The first category is anecdotal but biologically plausible. The second category misrepresents the science in ways that could lead patients to make decisions that compromise their care. Mounjaro's side effects are real, and in some cases serious. Gastrointestinal effects, nausea, vomiting, diarrhea, are the most common and affect a significant proportion of users, particularly at initiation. More serious concerns include pancreatitis, gallbladder disease including gallstones and acute cholecystitis, and thyroid concerns. Tirzepatide carries an FDA black box warning against use in patients with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. And muscle mass loss, which accompanies the weight loss produced by Mounjaro, is a specific concern for older adults with arthritis, in whom sarcopenia is already a risk factor for joint degeneration and falls. For adults with osteoarthritis who also have obesity or type 2 diabetes, and who meet the approved indications for tirzepatide, the weight loss and potential direct anti-inflammatory benefits make Mounjaro a genuinely reasonable discussion to have with a prescribing physician. The joint benefits, while not formally approved as an indication, are plausible and supported by emerging evidence. This is an appropriate informed conversation about a medication the patient may need for another indication that may provide joint benefits as a secondary outcome. For adults with arthritis who do not have obesity or type 2 diabetes, and who would be seeking Mounjaro specifically for arthritis outside of any approved indication, the evidence does not currently support this use. The risks are not trivial, and the comprehensive evidence-based non-surgical arthritis management program we have described throughout this series, which has far more established clinical trial evidence than any GLP-1 arthritis application, remains the appropriate first-line approach. The self-prescribing and online purchasing of tirzepatide for arthritis, which is occurring in some patient communities that have enthusiastically embraced the preliminary evidence, carries additional risks. Tirzepatide dosing requires careful titration. Without medical supervision, patients may use inappropriate doses, fail to recognize early signs of serious adverse effects, miss the monitoring that safe tirzepatide use requires, and substitute a promising but unapproved medication for the established treatments that are the appropriate standard of care for their condition. The honest assessment is this: if you have osteoarthritis and you also qualify for Mounjaro under its approved indications, obesity with a BMI above 30, or overweight with a weight-related health condition, it is a reasonable medication to discuss with your physician for its approved purposes, with the understanding that joint benefits may accompany the weight loss, and that the STOP-NE-OA trial may eventually provide the definitive arthritis-specific evidence currently absent. If you have arthritis without the comorbidities that make you an appropriate candidate for tirzepatide under its approved indications, the claims that Mounjaro is a proven arthritis treatment are not supported by the current evidence. The science says, promising but preliminary. The biology says, plausible and mechanistically coherent. The regulatory status says, not approved for arthritis. The risk profile says, significant and not trivial. And the evidence comparison says, the non-surgical management program documented across this series has substantially more established clinical trial evidence for arthritis benefit than tirzepatide currently does. But watch this space. The next few years of clinical trial data from STOP-NE-OA, from the rheumatoid arthritis trials in progress, from the post-marketing data on millions of tirzepatide users will determine whether Mounjaro's story in arthritis is ultimately one of innovative treatment, well-intentioned premature enthusiasm, or genuine breakthrough that the initial evidence suggested and the rigorous trials confirmed. The science will tell us, and when it does, this channel will be here to explain exactly what it shows. The practical guidance for adults with arthritis who are considering discussing Mounjaro with their physician deserves more specific articulation. For adults with knee or hip osteoarthritis, who also have a body mass index above 30 or above 27 with a weight-related comorbidity, tirzepatide is a medication that their physician can prescribe for its approved weight management indication, and the joint benefit conversation is an appropriate secondary discussion. The questions to raise in that conversation include, is my BMI and comorbidity profile appropriate for tirzepatide under its approved indications? What are the monitoring requirements, including thyroid function monitoring given the black box warning, and regular assessment for gastrointestinal complications and gallbladder disease? Should I be taking adequate protein supplementation and engaging in resistance exercise to preserve muscle mass during the weight loss that tirzepatide produces? And what would constitute a meaningful joint benefit response at what point in time? The protein and resistance exercise dimension is particularly important for older adults with arthritis considering tirzepatide. Clinical trials have documented that a significant proportion of the weight loss from GLP-1 and dual GIP and GLP-1 receptor agonists is lean mass muscle rather than exclusively fat. In the SURMOUNT1 trial, approximately 40% of the weight lost with tirzepatide was lean body mass. For older adults with arthritis in whom sarcopenia is already a risk factor for joint degeneration, fall risk, and reduced functional capacity, the preservation of muscle mass during tirzepatide-induced weight loss is a clinical priority that requires specific interventions. The research consistently documents that combining tirzepatide with adequate dietary protein targeting 1.2 to 1.6 grams of protein per kilogram of body weight per day, the recommendation for older adults in our arthritis prevention video, and with regular resistance exercise significantly reduces the lean mass loss relative to fat mass loss, preserving the quadriceps and hip abductor strength that protects arthritic knee and hip joints during the weight loss process. This integration tirzepatide for metabolic weight loss, high-protein diet to preserve muscle mass, resistance exercise to maintain joint-protecting muscle strength is the framework within which tirzepatide could reasonably contribute to a comprehensive arthritis management plan for appropriately indicated patients without the muscle mass depletion that would undermine the joint protective benefits of the weight loss itself. For adults with rheumatoid arthritis or other inflammatory arthritides who are also overweight or obese, the emerging evidence from the 2025 GLP-1 and rheumatoid arthritis studies is promising but requires specialist guidance before action. The interaction between tirzepatide's immune modulatory effects and the mechanisms of conventional DM/ARDS biologics and JAK inhibitors has not been systematically studied, and the potential for either synergistic benefit or unforeseen interactions requires the clinical judgment of the treating rheumatologist. The appropriate positioning of tirzepatide in the rheumatoid arthritis management landscape as a potential adjunct to established disease-modifying therapy rather than as a replacement for it is the context within which its immune modulatory benefits are most safely explored. The broader question of why GLP-1 receptor agonists remain absent from the formal treatment guidelines for hip and knee osteoarthritis despite the growing evidence of benefit was addressed directly in a commentary published in our MD Open in September 2025. The authors noted that symptomatic knee and hip osteoarthritis are excluded from the qualifying indications for GLP-1 medications despite robust scientific and clinical rationale, and argued that this omission has concrete consequences for the patients who cannot access these medications under their current licensing framework for a condition that causes significant disability. The commentary calls for updated guidelines and licensing applications that reflect the emerging evidence, a process that the completion of the STEP9 successor trials and the STOP-NEO-A trial is intended to accelerate. The cost dimension of Mounjaro for arthritis is one that deserves honest acknowledgement. In the United States, Mounjaro and Zepbound carry monthly costs that, without insurance coverage for the weight management indication, can reach $1,000 or more per month. Insurance coverage for tirzepatide for weight management, the indication most relevant to osteoarthritis patients with obesity, is inconsistent across payers and has been the subject of ongoing coverage disputes. For many arthritis patients who might benefit from tirzepatide's weight loss and potential anti-inflammatory effects, the cost barrier is a practical reality that the clinical evidence, however promising, cannot overcome without broader insurance coverage. The comparison between tirzepatide's cost and the cost of the comprehensive non-surgical management program we have described is instructive. The dietary changes, the exercise program, the proven vitamins, the topical diclofenac, and the periodic PRP injection that constitute the evidence-based non-surgical toolkit are collectively far less expensive than sustained tirzepatide therapy and have, as we have established, substantially stronger and more directly arthritis-specific evidence of benefit. This cost-effectiveness comparison is not an argument against tirzepatide for appropriately indicated patients. It is a reminder that the most evidence-supported arthritis interventions are accessible to every patient regardless of their ability to afford a monthly injection of a recently developed medication. The complete and honest picture of Mounjaro in the context of arthritis management is one that neither dismisses the genuine scientific promise nor exaggerates it into the kind of certainty that the current evidence cannot support. It is a picture of a medication with a plausible and partially validated mechanism of benefit for arthritic joints, currently approved for other indications, being studied in the disease-specific trials that would establish or refute its arthritis efficacy, with real risks that require medical supervision, and with a patient population for which the benefits are most accessible, those who qualify for its approved indications and who can afford it, that does not fully overlap with the arthritis population that may be most attracted to the social media enthusiasm around it. Navigating that gap between the enthusiasm and the evidence, between the cost and the access, between the promise and the proof, is exactly what informed health literacy is for. And this channel exists to provide it. The science of GLP-1 receptor agonism in arthritis is genuinely interesting, and it is developing. Whether Mounjaro eventually earns its place as a recognized component of arthritis treatment for the right patients, with the right evidence, under the right medical supervision, is a question that the next several years of clinical trial data will answer. The intellectual honesty required to hold both the genuine promise and the genuine uncertainty simultaneously, without collapsing into either uncritical enthusiasm or reflexive dismissal, is the stance that serves arthritis patients best. That is the stance this channel takes, and it is the stance that the evidence, examined honestly, supports. The patient community dimension of the Mounjaro arthritis conversation, the role of social media, patient forums, and peer information sharing in shaping how arthritis patients perceive and access information about emerging treatments, deserves specific acknowledgement because it reflects a broader truth about how health information flows in the digital age. The anecdotal reports of dramatic arthritis improvement after starting Mounjaro that circulate in online communities are not fabrications. They are real experiences reported by real people, many of whom have found relief they had not found through conventional management. The question is not whether these experiences are genuine, but what they actually tell us about Mounjaro and arthritis in a scientifically meaningful sense. Individual positive experiences, however compelling, do not establish that a treatment works for the population. They establish that it worked for that person, which could reflect the weight loss mechanism, the anti-inflammatory mechanism, the placebo response, the natural fluctuation of arthritis symptoms, or some combination of all of these. The randomized controlled trial design, in which patients are randomly assigned to active treatment or placebo without knowing which they received, is specifically designed to separate the effects of the treatment from all of these other contributors. No amount of positive anecdotes, however numerous, can replace the rigor of that experimental design. At the same time, the accumulation of consistent anecdotal signals, when they are mechanistically plausible, when they appear across diverse patient populations and contexts, and when they align with the signals emerging from clinical studies legitimately informs the clinical research agenda. The STEP9 trial and the STOP-NEO-A trial were designed in part because the clinical and anecdotal signals justified investing in the rigorously controlled studies that can actually answer the question. In that sense, the patient communities that have shared their Mounjaro arthritis experiences have contributed to the scientific process not by proving that tirzepatide works for arthritis, but by generating the signal that makes the clinical trials worth doing. The role of this channel and the reason it is worth your continued engagement is to provide the scientific context that transforms individual experiences and clinical signals into the complete, evidence-calibrated picture that allows you to make informed decisions about your own care. Not to celebrate every promising finding as a breakthrough. Not to dismiss every exciting story as anecdote, but to hold both the genuine promise and the genuine uncertainty simultaneously, with the intellectual honesty that the science requires and that the patients who are making real health decisions deserve. Mounjaro for arthritis is at the intersection of genuine scientific promise and premature marketing enthusiasm. Understanding that intersection specifically, honestly, with the evidence-based calibration that this channel has built across this arthritis series is what positions you to make the best decision for your own health. In conversation with your physician, with full awareness of what is known and what is not yet known. That is the informed position. And it is where this conversation ends, and your next physician appointment should begin. If this video gave you the honest, evidence-based picture of what Mounjaro actually is, what the science actually shows, and what the advertising claims get right and wrong, please support this channel. Hit the like button right now. Subscribe if you have not already. Share this video with someone who has seen the Mounjaro arthritis claims and wants the real story. And leave a comment below. Tell us whether you have used or considered Mounjaro for your arthritis, what your physician has said about it, and what you are going to take from this video into your next medical conversation. We read every comment. Thank you so much for watching. See you in the next one.